Thank you very much, Boyd. And it's a real pleasure to be here. Thanks for the invitation and the award. The stuff about neurology, psychiatry, neuropsychology, psychology, I think this venue is the right place to do what I'm going to do here, which is to show you some ways in which we could try to deconstruct symptoms which have labels, going back to what Simon said, that differ amongst different specialties. And before I move on, it reminds me to say that if you want to read Simon's argument, they're articulated beautifully in an essay in Brain. So please do read that. And I also want to thank a huge number of people who've been involved in the work I'm going to show you, particularly to Sanjay Manohar, to Sijia Zhao, and also Yusuf Saleh, whose work you'll see quite a lot of today. There are lots of people we know with different levels of motivation. In our families, our friends, dare one say it, our colleagues, there is a whole range of motivation. And this is emblematic of one end. This is the character Oblomov, created by Ivan Goncharov, a 19th century novelist, who describes this young man. He's inherited an estate in Russia somewhere, and the serfs are just pulling out their hair because he is doing nothing. Right? He's your ultimate chaise longue potato that is doing absolutely nothing. Right? And at the other end, we also have these people, don't we? And I'm sure you've got those people that you know. They can't do enough for you. You say, could you do this for me? They say, I can do more than that for you. I'll put a backpack on me and I'll run up that hill for you. And we just accept these people as being representative of different levels of motivation in health. But of course, in brain conditions, let's put it that way, there are a whole group of conditions that are associated with loss of motivation. Apathy, anhedonia, depression, and if you look further, for example, in the schizophrenia literature on negative symptoms, you'll see a whole bunch of other definitions and labels. And today I'm going to focus on apathy because it's a condition that we've worked a lot on, but one of the things that will emerge in this talk is what is the relationship between what a neurologist might call as apathy and a psychiatrist might call anhedonia. And this isn't just a sort of academic issue, because there are no licensed drugs for apathy, and there are also really poorly specified drugs that work on anhedonia. In fact, many treatment-resistant depressive patients actually have a lot of anhedonia. It's difficult to treat. And there are now animal models which try to understand the circuitry underlying these motivational deficits. But it's important to get the terminology right. For example, this one considered that what they were looking at was anhedonia, and as Sijia and I responded to this, is actually far more like what we would call apathy. So it's important to try and get these definitions right, because if we're developing animal models of human conditions, we need to know how a rat feels depressed or anhedonic, or is it just something else that we might call apathy? So how are we going to do this? And I'm going to try two different routes. One is a deconstruction using cognitive neuroscience, the tools that we've developed. And the other one, which we might get into, is phenotype in terms of symptom granularity, looking at the symptoms and trying to see what is the relationship between a particular symptom and the label that we give it as a syndrome. So I'm going to start because 20 years ago, I wasn't interested in this at all. I was doing attention research and work on memory. But this program of research really started when I was at the National Hospital for Neurology and at UCL. We received a letter about a relatively young man in his 30s who'd unfortunately had a stroke, but he recovered dramatically, was back at work within a week. The problem was that he had become incredibly different from what he'd been before. Previously, he'd been a highly sociable, gregarious person, very, very productive at work. And now he seemed not to be interested in anything, wasn't bothered to do anything. His friends were worried, suggested he sees his GP, who thought he might be depressed, started him on an antidepressant. It made no difference. He eventually got fired because he wasn't really doing well at work, and he couldn't even be bothered to go and get any unemployment benefit. So his very kind friend said, why don't you come and stay with us for a little while, which he did, and they promptly regretted it because he did nothing all day long. He just sat there in the chair, waiting for them to come back, cook for him. They had to prompt him to go to have a shower because he'd become a very, very disheveled person. And when we saw him, and it was a real effort to see him because he was so apathetic that he didn't want to come to these clinic appointments. I had to call him up to get him there. He wasn't depressed. In fact, our psychiatry colleagues at the National Hospital also saw him and didn't think he was depressed. He had just developed this profound lack of motivation. And what was his problem? Well, he had these, not one stroke, but these two tiny little strokes in the basal ganglia, in the ventral parts of the basal ganglia. And this is now well reported in a small number of cases. Bilateral lesions of the basal ganglia can lead to a pathological apathy. As can, for example, bilateral lesions of the medial frontal cortex that encompass the anterior cingulate cortex. This has been known for a long time, and its most extreme form, of course, is what we might call akinetic mutism. Someone who doesn't appear to move or speak spontaneously, but nevertheless can do all these things if you ask them to. Right? If prompted, they do it. Of their own volition, they don't do it. Now that's interesting, and we began to think, so is there a biological basis for our man's apathy? Is there a biological basis that might be the cause for him developing this apathy? And if we look deeper, what we find, and I'm compressing a huge amount of neurobiology here, is that the ventral parts of the basal ganglia, there you see in red, are highly connected to the ventral tegmental area, the dopaminergic region which runs into the substantia nigra. And of course, there are complex relationships between the basal ganglia and the medial frontal cortex, and dopamine here is a key neuromodulator. And we're very well aware of dopamine in the substantia nigra being very important in terms of the motor symptoms of Parkinson's disease. What I really started to look into then was, well, what about the basal ganglia and motivation? And that sort of reading led me to this. This is the lamprey. It's the oldest vertebrate, 360 million years old. It survived for that long in this form. Why is it so successful? Well, if you take a look at the lamprey, you get a good idea of why it's successful, because it has this amazing predatory ability. If you get very close, you'll see what I mean, right? It's not something you want to meet in the river. In fact, it comes out of the water at times, which is a frightening thought. But that's why the lamprey has been successful. And it also is the oldest vertebrate with a basal ganglia. So what is the lamprey's basal ganglia for? Turns out some people have framed this as motivation for action. Right? What kind of motivation cues? Well, motivation for food, sex, and if you're out the water, you want to get back in the water, motivation to get back in the water. So these are the simple, primitive motivational drives for the lamprey. And the work, for example, by Stan Grillner has shown that the basal ganglia of the lamprey are very, very important for this motoric role, but in terms of linking motivational cues to action. That's the key thing I want to get across to you. And it turns out that a lot of work has suggested, not only in the lamprey, but in other animals, including ourselves, that motivational cues like hunger, thirst, sex, and even drugs use this same common pathway that I'm going to talk to you today about. In fact, if you think about hunger over the next couple of years, over the next couple of hours, you're going to get this sensation, this urge, this motivational drive that's going to say, I need to have some food. Now, you're not going to expire if you don't have it, but somewhere deep inside is this this urge that's urging you to go and find food, right? And that is a motivational signal to act. And it turns out that drugs of addiction, almost all drugs of addiction, use the same pathway. This system is the one that's been identified and implicated in almost every drug of addiction, going from cocaine to alcohol. And the final point for this audience, of course, is that we're very well aware that too much dopamine, for example, in patients with Parkinson's disease, can flip them into an impulsive state. So we have evidence that if you target the basal ganglia, like in our patient, or the medial frontal cortex, you can get an extreme form of loss of motivation, apathy. And it's also this system which seems to get hijacked in drugs of addiction or in impulsive behavior, for example, in Parkinson's patients who might be given too much in the way of dopaminergic drugs. So that's interesting. We looked very closely at this guy, and to cut a long story short, what we found was the reason he wasn't bothered was nothing incentivized him. When I asked him why he didn't do anything during the day, and what he would normally do, he said, I'd listen to some music. Why aren't you listening to any music? I can't really have the time to put together my music system. How long will it take? 5 minutes, right? So that outcome, the rewarding outcome of putting in 5 minutes work, was not worth it for him. The effort wasn't worth the reward. So in him, with other kind of techniques, what we showed was that he wasn't really sensitive to any rewarding outcome. And therefore, we thought, okay, let's try a dopaminergic medication. And we tried him on levodopa. It made really no difference. Over 3 months, it really made no difference. Clinically, it made no difference in his reward sensitivity, which we measured in other ways. And we were about to give up, thinking we're not going to get any further here. But actually what we tried was ropinirole, a direct dopamine receptor agonist. And 3 months later, this man who was in a terrible state came back to us, and I didn't really recognize him in the waiting room because he was in a suit, he'd had his hair cut, he had a briefcase because he had a new job, and the most amazing thing, he had a new girlfriend. And he would never have done that because he did nothing all day. He would never have met anybody. So, okay, he is an amazing rarity. The neurological condition is an amazing rarity. But these lesions extinguished his motivation, and we could restore it with a drug that we already had, a drug that targeted the dopamine system. Now, it actually turns out that apathy is very, very common across conventionally neurological diagnosis, but also if you look at people with a diagnosis of depression or schizophrenia, they would also qualify with the criteria for apathy. Today I'm going to focus on a few conditions to show you examples of what we've been able to do in terms of deconstructing this syndrome. But before we get there, I also should say that emerging evidence suggests that if we look at healthy aging, it turns out that apathy is a really important issue in terms of the likelihood of developing dementia. And it interacts with any cognitive impairment. So you can see at the top, normal cognition, no apathy. Then we've got normal cognition with apathy, mild cognitive impairment without apathy, and then if you have mild cognitive impairment plus apathy, your likelihood of getting a diagnosis of dementia is much, much higher over the next 10 years. So this is an important problem because it might be a marker of what's to come next. So how do we define it? These are some European guidelines I was involved with at some stage. It's got to be something which leads to a reduction of someone's spontaneous, goal-directed activity, and it could be in many different domains. It could be just something you see behaviorally. It could be what some people have called cognitive, lack of curiosity in what's going on in the world or people around you. It could be emotional apathy or social apathy. You know, we know lots of people who are very good, very, very motivated at work but absolutely hopeless socially. So you can get these dissociations between social, behavioural and other types of apathy. You've got to have two of these affecting you for a month or more, and it's got to be something that's really clinically significant in your life and something that can't be explained by other triggers. Now, I'm just going to show you a video of a patient. I hope you'll be able to hear this. If the people at the back could put the sound on for me. Yeah, and this is a patient who has developed apathy. She's not depressed. She's got full insight, in this case, about the problem, and she's going to be talking about him, and him is her husband, who has become incredibly frustrated because she used to be the matriarch. She used to run the household, keep it clean. She used to cook for him, and now she really isn't bothered to do anything. If I was a fly on the wall, watching you at home, what would I see you doing during the day?
I suppose sitting, watching television, which drives him mad. I did used to book read, but I don't seem to be doing that much these days. And that's basically it, really.
So watching the television. Yeah. Anything else?
Can't think of anything, really.
In the past, would that have been you?
No.
What would we have seen if we'd been a fly on the wall a few years back? What would we have seen?
Me buzzing around, doing things, going out shopping, coming back, you know, being busy all the time. And I just slowed down and more or less come to a halt, me really.
Yeah. And you said you used to enjoy reading.
Yes.
So what's stopping you reading?
Absolutely nothing. Just that I can't be bothered, I suppose. It's easier to watch a screen and read a book. I keep threatening to pick up a book, but I just don't get there.
Some of my students have said the same thing. She's not the only one. But you can see what's happened here. She has full insight. Not everybody with apathy does have that, but you can see that she understands that she's not doing these things. She just can't be bothered to do it. So how do we get a handle on trying to understand what's under the bonnet, what's underneath these problems? And the way we've tried to do it is to just go back to the drawing board and say, why do we do what we do? Why on earth are you here when you could be doing something else, right? Other people are making the choice not to come to this. So let's think a little bit about what leads us to do what we do. And this is a cartoon schema where we've tried to think of some of the things that might be involved. I'm not saying this is comprehensive, and you may say there are lots of things I would take out of this, but let's give it a go with this. So the first thing is something that we've called option generation. Now imagine that you were not able to think of anything that you could do apart from come here. You know, you'd come here. But most of us normally think about the possibilities of what we could do. And then we make some sort of cost-benefit decision about the ability to do this or something or else. But if someone cannot generate those options for behavior, they might look very inert. They might not do anything because they're actually not able to generate those options. And to cut a long story short, we looked at this in healthy individuals and were very excited because we looked at self-reported motivation scores and an objective measure. I won't go into the details of how we did that, the number of options people generated in a fixed amount of time. And we were very excited because there was a very strong relationship in healthy individuals between how motivated you are and your ability to generate options for behavior. But it turns out that this is not the problem, at least in patients with Parkinson's disease and apathy that we've seen. They were completely able to generate options for behavior. So we were a little bit low about that, but it's a very clear-cut result. This isn't the problem in these patients. So the next thing that we were interested in is this cost-benefit decision-making. As I said, you could choose to do lots of different things. Why are you here? For some reason, you thought this was the most interesting thing you could do today, and other people didn't. But you evaluated the possibilities and thought, if I look at the potential reward of coming here against the effort that's required to come here, I choose to do this over other options, right? Because we can't do everything simultaneously. We've got to select one thing to do. And so this has turned out to be a really interesting area. And to really make this concrete, every time we're making a decision, you can think of it as a sort of hill to climb. Is this particular outcome worth the hill in terms of the effort required to achieve it? And for each of us, we have a very, very different subjective views about whether this much effort feels like a little bump along the road for someone like this, or this much effort feels like something I just couldn't do, right, for Oblomov. In my own household, I don't know about you, but in my own household, a really good example is the dishwasher, right? You can find that people will bring things to the dishwasher, but they won't actually put them in there. That becomes too much of an effort. So that's what I'm talking about. In rodents, who are given an option between, on the right-hand side, bland laboratory chow, and on the left-hand side, some delicious high-calorie food, rodents are willing to scale a wall to get to the food on that left-hand side. Okay, but different rodents will, have different breakpoints. Some are really willing to scale high up a wall. Others are not willing to go up more than a very small wall. That's where you can find out the individual differences about how much effort someone is willing to put in for a particular rewarding outcome. And it turns out that if you deplete a rodent of dopamine from that ventral basal ganglia region, the nucleus accumbens, or if you give it medial frontal lesions, what you get is a situation very analogous to what happens in humans. They are no longer motivated to go for the high rewarding outcome. Instead, they go for the bland laboratory chow. Okay? And some people have framed this as sort of two different phases of behavior. And it's been popularized as wanting versus liking. Now, liking is the pleasure you might get, the hedonic experience you might get from actually having the food, for example. Whereas wanting is the motivational drive to go and seek it. And it turns out it's the depletion of dopamine which leads to a problem in terms of a deficit, in terms of the drive, the wanting, but it doesn't change your hedonic pleasure. If you give a rodent the high-calorie food, they'll still enjoy it. They seem to really enjoy it. It's they can't be bothered to go and get it, to work for it. Okay, and it also turns out that similar regions in the human brain, identified with functional imaging, are related to evaluating reward. That includes the ventral parts of the basal ganglia here, and also effort. That includes parts of the anterior cingulate cortex as well as the insula. This is a nice review in brain by my colleague Matthias Pessiglione in Paris, which looks at this network of how people evaluate whether something is rewarding enough to put in the effort. So we've taken these ideas and looked at patients who have different levels of motivation. And the task we deployed was a very simple one. Here are some apples on a tree, and the number of apples here gives you an indication of the reward because they'll translate into a monetary reward later. This yellow line on the tree tells you the amount of physical effort you have to put in to get it, and we scale that to your physical abilities. So it doesn't matter if you're very muscular or not. This is how it works. If you're not willing to work for this amount of reward, you squeeze to say no. If you are willing to work, you have to squeeze to get that level of force required to get the reward. Okay? Very simple. So we've got a parametric space here, what neuroeconomists might say, we can manipulate parametrically reward and effort. That's all we're doing, right? And it turns out that if I give this to you, you will be very, very willing, the yellows show how willing you are, when you are given a very high level of reward. But if the reward is low and the effort is high, you're more likely to say, no, I'll just move on, thanks. Right? So we can work out the space in which you're willing to put in the effort for different levels of reward. We can work out subjectively for you where you're willing to work. And if we do this in patients with Parkinson's disease, we can ask the question, is the problem with apathy something where you have reduced sensitivity to reward, like our patient with the basal ganglia lesions, who really nothing was rewarding enough? Or is it hypersensitivity to effort? Is it that you're really not really interested in putting in the effort? Of course, it could be either of these, or even both. Now, it turns out that if we look at this set of options when people are tested with Parkinson's disease, with apathy and without apathy, it turns out there is a difference between the motivated people and the apathetic people. This is, it looks complicated, but it's really simple. It's the subtraction between the motivated Parkinson's patients and the apathetic Parkinson's patients on this task. So if there was no difference, we'd just be at the grey floor. But there is a difference, and the difference is that the motivated people are willing to work for low rewards, right? Everybody's interested in working for high rewards, but the motivated people are willing to work for low rewards, which the apathetic individuals aren't. So this is the finding if we look at patients with Parkinson's disease who are motivated versus those who are apathetic. Now, because they have Parkinson's disease, we can test them on and off their dopaminergic medication. And when I say off, we're just asking them not to take those medications in the morning, right? That's all we're doing. It turns out you get a difference. Dopamine, being on dopamine, influences behavior on this task, which cannot be explained by simple motor changes. And the effect is that if you're on dopamine, you're more willing to say, yes, I'll do this, particularly at the high effort, high reward offers. Just let you absorb that for a minute. One key thing, though, one key thing that emerged from this was this result was the same whether you were apathetic or not. So the two conclusions here are dopamine modulates your choices on this task, which looks at your ability to say yes or no for effort for this reward. But a little nuance is this task doesn't differentiate between if you're apathetic or not when you're on dopamine. And I'll come back to this point later on. So all the patients showed increased choices when they were on dopamine. Okay? Now, we have a sort of a very cross-disease program of work, and we looked at this also in patients with small vessel disease who also have a high likelihood of developing apathy. And we first chose to look at CADASIL, an autosomal dominant condition which leads to early onset small vessel disease. And we did that because it's a very pure pathological model of small vessel disease, which is not contaminated by other neurodegenerative conditions, for example, Alzheimer pathology. And when we did that, we found the same signature. CADASIL patients who are apathetic are less willing to work for low rewards than their motivated counterparts, right? So very similar behavioral signature across two completely different pathologies. And then we also tried to look at this in more sporadic, more common small vessel disease, the kind of patients you might see who've had a background of high blood pressure, diabetes, and so on. And there we found that there was this same problem, that the apathetic patients were less willing to work for low rewards, but we also found hypersensitivity to effort. So in this case, we actually found both the sensitivity to reward and the sensitivity to effort was affected. And in small vessel disease, because of the imaging characteristics, we could take this a little bit further and look at the brain networks, the white matter networks that are compromised in patients with apathy versus those who don't have apathy. And there are many regions that are affected, many white matter tracts, but I just wanted to point out that this includes the anterior limb of the internal capsule, which connects the basal ganglia to the medial frontal cortex. And it also includes the cingulum bundle, which connects the medial frontal regions, the different medial frontal regions, with each other. So that's quite interesting, because this maps on to our view that the basal ganglia and the medial frontal cortex are really critical to this motivation to act network. And interestingly, if we just took the same patients and now looked at those who were classified as being depressed versus those who weren't, there was absolutely nothing, right? So at this level, that's interesting, because it suggests that apathy biologically is different from the patients who have depression. As we'll see, there are people who have both depression and apathy. Okay, and to just show you a little bit more, we looked at this next phase because physiologists realize that there's probably a stage of behavior here which we might call arousal in some way, just getting ready to act. And one way to look at that is pupillary responses. Here is a cat which is about to pounce. Just look at its eyes, look at its pupils, if you will. Those pupils dilate before the action, right? And it's a physiological measure of getting ready to go. And we can do that in you and me, where we look at your pupillary responses before you make a saccadic eye movement to a rewarding outcome. I won't go into the details, but in brief, we could do this also in Parkinson's disease patients with and without apathy. And what we found was that the motivated Parkinson's patients show this pupillary dilatation before action to a rewarding outcome, whereas the apathetic patients have really blunted pupillary responses. So here again, there's a physiological marker of the differences between these two groups. Now, curiously, because we could also look at them off and on dopamine medication, we found that actually the apathetic patients showed more of this reward sensitivity, the pupillary response to different levels of reward, when they were on dopaminergic medication. But again, and I'm coming back to this point later on, so did the non-apathetic patients. So dopamine does make a difference to reward sensitivity as measured by this physiological index, but it doesn't discriminate between the apathetic and non-apathetic individuals. Okay, and one of the other things that we really wanted to look at was the ability to sustain effort. I'm sure you know lots of people who start things but never complete, right? The non-completers are a real pain, and what you want to do is not only measure if someone starts something, you want to be able to measure their ability to persevere. So Sanjay Manohar and Yusuf Saleh looked at this in a very simple computerized task, which you can do online. This is the finishing line, and your job is to press a little keyboard as fast as you can to get this red line up to the finishing line. You've got a short amount of time to do it in. That's your job, okay? And in the standard task, that's all you have to do. And in the conditions that we looked at, that's all you have to do. You don't know anything else is going to happen. But in some conditions, we set you back. And we want to see how you respond to a setback. So you're going along here, and then we'll set you back, right? We push you back. Or you're going along here, and then just to make life harder, we just move the finishing line. It was their idea. And we can also look at what happens when you get an unexpected uplift. So you're here, you're going along, and then we help you out, right? We push you further towards the finishing line, and we could also bring the finishing line closer to you. And for the experimentalists, we also have some control conditions where we have catch trials where we make those visual stimulations, but there's no real change in the level of motivation that would be triggered by it, just to look at that. And this is what happens in young people before those perturbations occur, and this is when the perturbation occurs. So you can see that when there is a setback, people start to press faster, because they've got to press faster to get to the finishing line. When there's an uplift, they slow down further, okay? The easiest way to see this, if we normalize by the pre-perturbation level, you can see again, setbacks mean that you press harder, faster. The uplifts mean that you can go slower, you can decelerate a little bit. And if we looked at young people with setback uplift and these sort of control trials, one of the interesting things is if we just look at their level of apathy, we can measure that just with some sort of simple questionnaires that we've developed. You can see that when there's a setback, everybody presses faster. When there's an uplift, most people without apathy can slow down. The sensitivity to these motivational cues is altered if you have apathy. You're less sensitive to either the setback or the uplift if you have apathy. That's just within 100 young people. What about patients? So here's Parkinson's disease, and here are the elderly healthy controls on this task. Here are the Parkinson's patients on their dopaminergic medication, and this is off. And it's not surprising that in this very motoric task, when you're on, you do better. You're pressing faster. That's to be expected. What's also interesting is if we look at setback and uplift trials compared to this control condition, here are the elderly healthy people. This is Parkinson's patients on and off. You can see this same degree of sensitivity between the two if we just look at these groups on and off. What about how apathy interacts with being on or off? And that's really interesting because if we divide the group between the people who have high levels of apathy and the more motivated people, the real big difference is in the setback condition, right? So in the setback condition, you can see that the people who have high apathy are far less likely to respond to the setback condition. And if we look at this in terms of what's happening with being on or off your dopaminergic medication, the bottom line is if you're highly motivated, it doesn't really make much difference on this task. But if you're apathetic, dopamine boosts you up, right up here, okay? And this is the only task I've shown you today where the effect of dopamine interacts with whether you're apathetic or not. So this is the bit which is very different from the other two experimental studies I've showed you. Okay, I'll let you absorb that a little bit more. And I said at the beginning that we wanted to look at this intersection between these diagnostic labels. So we did that. And actually, there aren't many data sets that allow you to do this. So we've had to do quite a bit of this on our own, but with a few other colleagues. So here are 3 different data sets. This is the combination of that. Looking at people who would qualify for the diagnosis of apathy, depression, or anhedonia. Now, it turns out there is a huge overlap. But there are people who have pure apathy, there are people who have pure anhedonia, there are people who have pure depression, at least in the way that we formalize it using diagnostic criteria. So actually, this is what happens if you look at a group of inpatients who have severe depression. At that level, it's almost all of these patients would qualify for these labels. So how can we get at this? And one way that we've looked at this is what we might call symptom granularity. Just go symptom by symptom or response to each question by question and see whether there are interesting differences between these conditions. Because you might think, well, it'll turn out that actually apathy is the same as anhedonia because they overlap, don't they? But actually, when we do a factor analysis, so along here are symptom by symptom questions for what we've developed, the apathy motivation index, the Beck depression index here, and the SHAPS. And to our surprise, if we just looked at a factor analysis, what we find is these segregate beautifully into the current clinical labels. So here is for anhedonia, this is for depression, this is for 3 different types of apathy, behavioral, social, and emotional. We've repeated this, and it turns out to be a little bit more nuanced, but essentially, although we have this big overlap between patients who could qualify for the diagnosis of 2 or even 3 of these clinical labels, when you look symptom by symptom, it turns out these things are actually segregating. So then we asked ourselves the question, all right, I mean, this is quite a lot for a clinician to do, and when you're pushed for time, you're not going to get them to do all these assessments. Could you just find the most important discriminating questions to make those diagnoses? And this is what Sija did. So she looked using a technique called minimal redundancy, maximum relevance, to see what were the questions that might be helpful in making a diagnosis of pure apathy or pure anhedonia or pure depression. And it turns out, just if you're interested in this, it turns out that actually it's not just the questions on apathy that allow you to make a diagnosis of pure apathy. You also benefit from having a question here from an anhedonia questionnaire and from the Beck, right? And similarly for the others. So by looking at the combination, the pattern of answers to these 10 questions, could you go away and work out whether your patient has apathy, depression, or anhedonia? And so she's put together this nice apathy, depression, anhedonia measure, which just includes the 10 questions. And it turns out, if you just use those 10 questions, you can do very well at discriminating pure apathy, pure depression, pure anhedonia. Not only that, we're not showing you the data here, you can do very well at finding the overlaps, the people who might have apathy and depression, or anhedonia and apathy as well. So that's quite useful, I think, from a clinical point of view. But it's actually quite puzzling in some other ways, because it turns out that these clinical syndromes, which can overlap, are also very, very distinct. So I think what it tells us is that we're a long way from cracking this, but the development of these terms might actually have some real utility, because they seem to discriminate between different people, and that suggests there might be different biological bases to them as well. Okay, so I'm going to stop there, try and keep on time. I hope I've convinced you that there might actually be a biological system which we could say is dedicated to motivation to act. And we've talked about the basal ganglia and the medial frontal cortex and a key role for dopamine, but I also hope I've suggested to you that dopamine may not be everything here, because it can have rather global effects in apathetic and non-apathetic people. That one way to try and unpick this is to deconstruct the kinds of processes that are involved in motivation to act. And the two areas that we found the most traction is in this ability to decide whether something is rewarding enough to put in the effort, and also to persevere in something you've started. And finally, just to make this point, that the overlaps between these neurological and psychiatric labels can be quite substantial. But it turns out, if you look at this symptom by symptom level, these things actually fall out as being very separate. My thanks to the Wellcome Trust, who've funded us for the last 26 years, and the NIHR at Oxford. And if you're interested in reading a bit further, these reviews, particularly I'd suggest this one, which has come up by my colleagues, is very good. And if you're interested in reading about the first case and others, which are, I think, have been quite revelatory to me, as Boyd mentioned, there's a book which I think is upstairs as well, but these cases in here have been really influential in my understanding of how brain disorders can tell us something about ourselves. Thanks very much.
I think we've probably got a minute or so. I'm going to interpret it in that way for questions. There's a few. I'm going to take chair's prerogative. So ropinirole, I definitely know that in my Parkinson's disease patients, dopamine doesn't always do the job, and ropinirole seems to give people a bit of a boost. Why was it, do you think, that ropinirole worked in that man and not dopamine?
Yeah, I mean, I think the other interesting thing is, why are dopamine agonists more likely to tip people with Parkinson's disease into impulsivity? And one potential mechanism is the direct stimulation of, let's say, D2 or D3 dopamine receptors versus levodopa having an impact across all those dopaminergic receptors. So I think that would be my most likely mechanism of action.
Thank you. So there was one at the back who I think was first. And then is there an online? Yeah, okay. So then we'll go to online and then
Fantastic. Thank you so much for the talk. It's a bit of an off-piste, question. I mean, we all agree that, we receive referrals that, they have a really vague, definition of apathy. But then there is one of the disorders that are not really commonly linked with apathy, is ADHD. And there are, many patients that describe this kind of, paralyzed state, usually when they're not on medication. Really, I would say, linked with reduced motivation. There were a few studies that showed, low dopamine. And some people say that this is also, maybe a state of apathy. I was wondering if you have any insights. Is this, similar apathy as in Parkinson's, something different?
I'm still not clear what kind of person you're talking about. Just explain.
ADHD.
Sorry?
In ADHD.
In ADHD. Yeah, okay. I mean, so it's not a condition I'm very familiar with, but what I do know from the reading around it is obviously you can get both apathy as well as impulsive behavior in ADHD. But yes, it's something that's been reported in terms of lack of motivation. Whether they would also qualify clinically, I think is an empirical question, yeah.
if we go online next, and then if you've got a microphone, and then we'll pass across to Simon. Paula, if you give it to Vaughan. Oh, sorry. That's coming. Sorry, we're just going online. Yeah, over here.
Thank you. Question from the online audience. This is from Frank Bessag. Stuporous catatonia can look like profound apathy. Does this give us potential insight into the mechanisms of catatonia?
I think you'd have to investigate it in terms of response to drugs. I don't know. Yeah.
If we go to Simon next, just here, just there. Great, and then...
in neurological practice, the most severe case of apathy I've seen are in callosotomy, or where there is a disconnection between the hemispheres. Are these problems bihemispheric, or do they require both hemispheres?
Usually you need bilateral lesions to create this. I actually haven't seen that in callosotomy, and I wasn't aware of that being a big issue, but... Yeah, I mean, and also, you also wonder about the local impact on the medial frontal cortex in these cases too. So I'm not aware of that, Simon, yeah.
So I think I took the microphone away from somebody, so I'll give it back to them for their question, and then I'll go to maybe 2 or 3 others.
In patients I've seen with profound apathy, which is mostly, again, after acquired brain injury, when you're confronted with this patient who sort of just sits in the chair all day doing nothing, you do wonder what's going on inside. And do you think that, and that can be very hard to establish, asking about it doesn't necessarily get you anywhere. Do you think that in these patients there is a kind of retreat into, was Oblomov spending his day daydreaming? Was his default mode network maybe a bit more active than other people's? Is there a sort of inverse to apathy, if you like, where there's some kind of retreat into an inner life, or is it more just of a deficit state?
Yeah, it may not be such a rich inner world. It could also be quite a vacuous inner world. So it's difficult. You're completely right. I mean, I don't think anyone's actually done that sort of, just talk to the patient long enough to try and discover that. And again, how much insight somebody would have is also problematic.
So if you could pass it along to Alan Carson at the end, and then if you could pass it back, we'll go to the front row over here.
Thank you for a wonderfully elegant talk. Medial frontal cortex, particularly bilaterally, is one of the commonest patterns of contusion in brain injury just because of flexing of the neck. And we see a lot of apathetic patients. I've always been rather cautious about pharmacological intervention,
Yep.
but not intervening is disastrous because they do disastrously badly with rehabilitation. What do you think, just in terms of practical application, should we be a little bit more gung-ho at prescribing ropinirole with careful follow-up and all due diligence? But how close are we to saying actually we possibly should start doing things?
Yeah. So I have the same caution in patients with frontotemporal dementia. I've never prescribed a dopamine agonist in that condition, although obviously apathy is a big problem, but so is concurrent impulsivity. So I completely understand, Alan, why you wouldn't do that. I mean, there are people who've used methylphenidate with varying degrees of success and published trials on that. And if you're interested, methylphenidate has been also successful in treating apathy in patients with Alzheimer's disease. There are 2 trials out there. So I do use ropinirole in off-license in people who've got apathy, but my impression is that it's more successful in younger patients who might not necessarily have widespread damage. It's more likely to succeed in the kind of case I've shown you here. But you wouldn't know unless you tried it. And I think the way to do this is slowly to titrate it up. I'm really super cautious. I start at a very low dose and bring it up, because we have also gone there where it was somebody with a traumatic brain injury who did really well on the medication, but his wife said, he's not quite there. Would we be able to increase it further? and that's when we tipped him into a state that wasn't good. He was very, very impulsive. Yeah. So we have to be careful.
Thank you. One really brief question just at the front, and then we'll finish.
Hi. Yes, following on from the question about traumatic brain injury and thinking about Alex Rose's talk yesterday about assessing mood in severe traumatic brain injury, do you think any of your experimental paradigms or imaging would have an application in that kind of assessment, differentiating apathy and depression in that population?
Yeah, I think we have to make a division between just a clinical assessment and trying to understand the mechanism. I don't think you need fancy imaging or any of these paradigms to work out if someone's apathetic as well as depressed, or has anhedonia, in what I've suggested. If you are interested in whether the mechanisms leading to that surface level phenotype are different, which we are, then we can do this. But I don't think you need that. You could try the 10-item questionnaire to work out whether someone would qualify.
Sorry, I guess I was thinking about non-verbal patients.
I see. Well, that's
with really profound injuries. Whether your methods could be applied to that population.
I think interpreting imaging results in someone in that sort of state of consciousness is going to be always very, very difficult. Yeah. You could try, as some of our colleagues have done, to sort of ask people to imagine doing things. Imagine they're playing tennis, imagine they're walking through a room, and they've shown that the different regions of the brain are active under those circumstances, regions that would be consistent with what happens in healthy people. But whether you could ask people to imagine, would you be willing to work for this kind of reward when you're in this sort of state? I'm not sure that would be very successful. Yeah.
Okay, thank you very much. If we can give another round of applause, and I'll just present the medals.